So in Malawi, 85% of the population lives at the last mile. So really, it's the vast majority of Malawians are here, and this is where access to health services is the most limited. Human resources for health to deliver care are limited, as we saw in the video and as we've been discussing today. There's only one doctor for every 44,000 people. You can imagine a high disease burden coupled with disruptions in supply chains, including shortages of essential medicines at the national level. And all of these compound the problems of the limited infrastructure, the poor information management and supply availability that we see at the last mile. And yet, despite these challenges and more, Malawi's making some really great strides towards improving access to quality reproductive health services. For example, Malawi's contraceptive prevalence rate has been steadily increasing from 35% to nearly 60% in just 5 years. Similarly, there's been a corresponding decrease in unmet need for family planning, and currently 97% of health facilities in focus districts in Malawi have at least 3 modern methods of family planning. So, with that in mind, we are all very fortunate to have our panelists here today to share more about the successes in Malawi, and in particular, the success made at the last mile. So, please join me in welcoming the panel members. I'll introduce them all once they're sitting on stage with me. Great, thank you. So, Ms. Fannie Kachale is the Director of Reproductive Health at the Malawi Ministry of Health. She is a registered nurse and midwife and has spent more than 20 years working to improve the health of women and children. She has been at the forefront of efforts, both nationally and globally, to increase access to reproductive health services, working with stakeholders from the community level all the way to the global level to bring attention to and build effective programs and resources to address inequities in the quality of maternal and newborn health services. And if that's not enough, Fannie is currently studying for her PhD in interprofessional health care leadership so that she can bring some of that learning to her career as well. Siti Ngawao, otherwise known as Siti Kachingwe, is the project manager for Engender Health's COPE for Contraceptive Security project in Malawi, which is funded by the Reproductive Health Supply Coalition Innovation Fund. Ms. Kachingwe is a nurse midwife and public health nurse practitioner and was also on the nursing faculty at the University of Washington, where she served as dean. Welcome. And all the way at the end is Mr. Matthew Ziba, the Supply Chain Program Manager at Village Reach in Malawi. Matthew brings a Master of Science in Supply Chain Management and a bachelor's degree in Business Administration, with more than 15 years of experience in supply chain management, hospital administration, and leadership positions at training institutions to the management of Village Reach's Pharmacy Assistant Training Program and supply chain portfolio in Malawi. So we will start by giving Fannie the floor, really, so that she can start and give us some of her perspectives on what has led to the success in Malawi.
Okay, thank you very much. Good morning, everybody. Like we heard from Jessica, 85% of the Malawians are in the rural area. And as a Ministry of Health, we actually took the lead in terms of supply chain management, and I think there has been commitment on the government side. So we have actually promoted the partnerships that are there in collaboration with the different stakeholders that are in the country. At national level, we actually have a reproductive health commodity security, which is very inclusive. It has members from the civil society, it has people from the regulatory bodies, and it also has the different partners. And they discuss on quarterly basis on issues of commodities in terms of availability, distribution, and stock status. At the district level and the health center, which is the primary health care in the rural area, we actually have advisory health committee, which includes people from the community who are aware of the commodities that come to the health facility, and they actually make follow-up so that they should be able to see how those commodities are being used. We actually have our parliamentarians also taking the lead. They are interested in issues of commodities, and they actually always are on the back of the ministry asking exactly what are you doing about such commodities. But I'll talk of the two most distinctive initiatives, which Siti and Matthew are also going to talk about at length. With Engender Health, we have initiated COP for contraceptive security, where we have been able to facilitate the management teams at the health facilities. This includes even the health center in the rural area, to improve systems' ability to make contraceptive methods reliably available for the clients. So the teams have been empowered, and they know how they should actually forecast and order the commodities, so that once women come, they should be able to find the commodities at the clinic. With the Village Reach support, the Ministry of Health has been able to train pharmacy assistants who are undergoing a 2-year course, and these pharmacy assistants are actually emphasizing on supply chain management. In most of the rural areas at the primary health care facility, we have improvised the health workers who are taking charge of the commodities, so we've often had problems. But with these pharmacy assistants who have been properly trained, they are able to do the proper logistics management information systems, such that there is increased storeroom management of commodities, there's increased data quality, and higher quality pharmaceutical practices in those health facilities, such that when the women come, they actually find the commodities that they want. There's also been a lot of governance structures in place, which are the technical working groups. I talked about the reproductive health commodity security, but also we have the family planning subcommittee, which also meet on quarterly basis. And here they discuss issues of RH commodities, including the family planning commodities. And also there is monitoring and evaluation where spot checks are done in the facilities to check on the availability of commodities. Thank you.
Great. Thank you, Fannie. I think you gave us a really good overview of what's to come, so appreciate that introduction. Siti, I'm wondering if you could, building on some of the introductions that Fannie just made, describe some of the work that Engender Health has been doing in more detail at the Last Mile, and how your work is contributing to the success in Malawi.
Thank you. Good morning once again. I'm here to share with you a brief overview of Engender Health project in Malawi. And the name of the project is called COP for Contraceptive Security. I want to start with the definition. COP are abbreviations, and it stands for Client-Oriented Provider Efficient Services. There are other technical COPs. For example, there's COP for circumcision, COP for reproductive health services, just to mention a few. But the discussion today is COP for contraceptive security. It is a methodology that addresses stockhouse at the district and facility levels. And this is done by providing the facilities a problem-solving framework that helps the management of family planning management. Initially, COP was developed by Engender Health, and it was piloted in Tanzania. And in Tanzania, as of now, they have scaled out COP nationally. In Malawi, COP started in 2014, and at that time, it was in 18 facilities. With support from the Reproductive Health Coalition Supply Innovation Fund, COP in Malawi has scaled up to 60 facilities. And I just want to describe how COP works at the facility level. First, there is a tool, which is a self-assessment guide, and facilities do assess themselves. And when they assess themselves, they come up with an action plan. And the action plan is composed of identification of problems. They do identify problems. And after they have identified the problems, they come up with root causes of the problems, and then recommendations. And they do identify somebody who will be responsible for following up the recommendations. And thereafter, someone who will see the dates of the completion of whatever recommendation that has been done. After this, then there is follow-up of the commodities, of the facilities. Remember, we are talking about contraceptive security at the last mile. So far, we have a few results. Now we have more commodities at facility level. And again, there are now trained designated members responsible for logistics and management for stocks at the facility level. And there are more family planning providers at the facilities. And this has helped the facilities and the women to be able to choose a method that they want. And the stocks have increased in these facilities. Thank you.
Great. Thank you. Matthew, as we saw in the video, and we're talking a little bit about some of the challenges at the last mile, we know that human resources is a real challenge in Malawi. I'm hoping you can describe some of the efforts that Village Reach has done to improve the delivery of care at the last mile by focusing on strengthening human resources.
There's a saying which says that get able hands to get the system working. You can have a system that is perfectly designed with all support there, but if you don't have trained hands, the system still will collapse. So Village Reach's effort in Malawi is to tighten the loose ends of the supply chain. There were a lot of inefficiencies, a lot of contraceptives and other pharmaceuticals expiring in the health services. There were a lot of stockouts and a few options for women in the villages at the last mile because the people who were actually managing the stocks were trained just for 2 weeks to do that. So Village Reach came in to Malawi to introduce a cadre that is going to manage these stocks at the last mile and make sure that there is efficiency at that level. So we introduced, through collaboration with the Ministry of Health and a training institution, a cadre of pharmacy assistants who are trained specifically to work at the last mile, to work at the health center, to make orders in time, to come up with the order quantities that are realistic with the consumption, but also to provide more pharmaceutical support at that level. And this has brought tremendous change at the moment. We work hand in hand with our colleagues here at COP. When they are going to do the supervision, they have seen a great difference between facilities that are managed by pharmacy assistants and those that are managed by community health workers who are loaded with other shifted activities at that level. So Village Reach is bringing in is strengthening the human resource for health at that last mile to bring good services to people at that end. Thank you.
Great, thank you. At the end of the video, we saw a phrase that said, no agency can do it alone. And I think that we all experience that to be very true. Fannie, I'm wondering if you could tell us a little bit more about the role of collaboration and partnerships at the work that you see being done in Malawi, both including civil society and the community, as well as efforts at the national level.
Thank you very much. Earlier on, I talked about the collaboration and partnerships that are there. we have this reproductive health commodity security steering group, which includes members from the regulatory bodies, directors from the ministry, stakeholders like even civil society, and they meet on quarterly basis, and their terms of reference is to actually discuss the stock status of reproductive health commodities, including family planning. So at these meetings, they actually have the presentation of how the facilities have fared in terms of the commodities that they have been receiving, also the logistics management information forms that they have been sending back to the ministry. And then Central Medical Stores is also part of this team, so they'll be able to discuss the issues like what is in the pipeline. Mostly our orders come through UNFPA and USAID, so we're able to share that information at those meetings, so there's no duplication. If, let's say, we are actually running out of a commodity, we're able to discuss. One of the partners would actually help us to airlift the commodity so that we don't experience those stockouts.
Thank you. Coming back to very specifically the Last Mile CTO, can you talk about how the Last Mile was part of the program design from the very beginning, and what your plans are sort of for the long term of the COPE project?
Thank you. The methodology itself is low cost and affordable by facilities. So it's so sustainable that it's very easy to follow, and a lot of people are able, within the facility, they are able to use it.
Okay, great. And Matthew, can you add on to the discussion about how you see the role of partnerships in the Village Reach programs, as well as some of the long-term plans for the pharmacy assistant program in Malawi?
The program, collaboration or working hand in hand with different stakeholders has actually made it quite easy for Village Reach to introduce the new cadre in Malawi. Change, the process of managing change can be very critical if you want to make a difference between success and failure. So by having a new cadre introduced into the system, somewhere would become suspicious as to what this person is going to be doing. He's taking over my work. He's going to do like some kind of checking what we are doing. Some have got attached benefits to that. So by working with the Ministry of Health and existing training institution, it made it very smooth for us to have this cadre smoothly introduced in the system, and they are now currently being viewed as a good complementary service to them. One of the courts of the clinicians in this health facility said that he has more time now to concentrate on doing the diagnosis, examining the patients and also write the proper prescription for patients, rather than spend more time, additional time doing logistical work. So collaboration has actually made these people to understand and also accept this cadre very well. Thank you.
Please.
Just want to add again that at the facility level, as we go with COPE for contraceptive security, we have a health advisory committee, which is a community-based committee, and this one is responsible for making sure that the facility have adequate stock for the communities. And that is, we work hand in hand with that committee, and of course with the Ministry of Health, and it's so sustainable that because the ministry has been in it and they have been everywhere with us, and supervision is commonly done by the Ministry of Health personnel.
Great, thanks. Fannie, I'm wondering if you could describe for us some of the unique challenges that you've seen in implementing programs with a last mile focus in Malawi, and some of the lessons that you could share with us as we're all focusing at this level.
Thank you very much. The challenges that we would actually have would be if we do not have adequate human resources to actually implement the services. And at times you would have the human resources, but they are not properly trained in terms of handling commodities. So that has been one area where we have actually worked on to strengthen. But also we have actually seen that in facilities where we do not have these pharmacy assistants, they have task shifted to either a health surveillance assistant or a midwife to actually do the ordering. Those facilities have had challenges at times of the stockouts, or maybe at times you don't even have the wide method mix that we advocate for. Thank you.
Great, thanks. Matthew, do you have anything to add about some of the last mile challenges that you've encountered or you've seen, or give some examples? I've heard you tell stories and show pictures of what storerooms looked like before there was a pharmacy assistant, and how working at that level we've learned a lot. Could you share with us some of your experiences?
Before we actually place a pharmacy assistant at the facility, we would go to collect some baseline data. And it's so pathetic to see the amount of contraceptives that are not usable, either because they are expired or they were not properly handled, actually shelved in the facility. And there is a lot of wastage that is happening. And yet facilities keeps on ordering medicines, ordering contraceptives and other pharmaceuticals to work in there. So there is a lot of wastage actually that was actually happening in those facilities. You also find that, as Fannie has actually alluded to, you find that there is only movement of one type of stock, while the other stocks are just lying there. So you only find less. For example, like depot is not moving, while the other methods are actually moving very fast. And in the end, you find them expiring on the shelf, meaning that the community wouldn't have a wider choice of a method that they would desire. And in addition to that, there also little information that is actually given to women in those areas. So women do not know what method is better for them that they have to go to. But this cadre has actually, because of their pharmaceutical knowledge and background, they provide more information, not just to the community when they're doing health talk, but also to health workers that are there. Thank you.
Great, thank you. So I've been asking a lot of questions, and I'm not sure how we're doing on time, but if there are any really burning questions that you have in the audience for any of our panelists, perhaps we can get some of those. Yeah. Yeah, Jennifer, you're the first one.
Would you hand up again? Who wanted to?
Thank you very much to the panelists for sharing such amazing work they're doing in Malawi. And of course, I commend the Ministry of Health for their involvement in all this work. It's actually key to sustainability of most of these activities, but also it shows the will in terms of moving forward. So I had a question. I don't know if maybe she didn't get a chance to talk about it, but it's a question around data. The data that we've been talking throughout this week about the use of data, the need for data to do decision making, and I probably didn't hear much about what they're doing in terms of using data. Do you have some kind of a health information system? How do you do this to be able to do the quantification, to be able to make decisions in terms of the contraceptives that has to be the quantification of contraceptives and all, any stockouts and all that. So I don't know if you could elucidate more on that.
Sure. Fannie, do you want to go ahead?
Thank you very much, Jennifer. I had talked about the Reproductive Health Commodity Security Steering Group. This is the group that actually receives all the information in terms of consumption of commodities, which includes the contraceptives as well as ORH supplies. We actually receive that information through we have a department at the ministry which corresponds with our central medical stores. The department gives the monthly stock status reports to these committee members. And then when we meet on quarterly basis, presentations are actually made, and we're able to actually pick out the districts that are actually not doing well. And in that committee, we have health zone managers. These are managers who are responsible for a few districts that are in their zone. So if there's a district which is not performing well, it's up to the zone officers to actually follow up with that district to actually see where the problems are. But also, I had talked earlier on about monitoring and evaluation where spot checks are done. So we are able to actually visit a facility and check on how they are managing their stocks in terms of even checking the stock cards, checking the actual commodities that are available in the stores, and also discussing with the district health management team on how they are faring. So that's where we actually get the issues of data.
Matthew, do you have anything to add about some of the work being done around data in Malawi?
Basically, this is actually the system that has actually been put in place, but still some more challenges are there where you don't have, you have either a cleaner who is actually handling the pharmacy, so the data is actually not there. And the people that goes to do the supervision, sometimes, you know, in developing countries, there's poor health financing. They might spend 3 months without doing the actual spot checks or supervision. So if you don't have a trained personnel there, the data that they actually rely on is the monthly LMI, Logistics Management Information System reports, which in most cases are inaccurate, have a lot of errors, or are missing some of the most crucial information. In an effort to alleviate that, we are working on bringing up a system that is going to bring a system that is going to help to identify the problems in data earlier on. Our colleagues from Zambia and Tanzania have opened LMIS, which Malawi is aspiring to extend it up to the health facility level. So data will be entered right from the health facility level, and there will be somebody will sit down and look at it periodically to see where problems are, and there will be a quick spot of problematic areas to go and support. So we are working on 2 fronts. One, bringing trained professionals to the health facilities, but also bringing up a system that can bring visibility to the data in the facilities so that they can quickly resolve identified problems. Thank you.
Good morning. Thank you for a very nice presentation about your experience in Malawi. My name is Soumya Ramarao from the Population Council. I had 2 comments. The first one was that I was delighted to hear both about not only stockouts, but overstocking, and the fact that it leads to expiration of drugs. I thought that was a good point, that we don't necessarily always stock together. We always talk about either stockouts with taking the primary focus. The second point related to that was, when we talk about COPE for commodity security, it's also we need to link it with your broader system strengthening that you do at the facility level, correct? Because providers need to also provide the range of choices that they have. And so if there is any discomfort or lack of training in providing one method, that's why, if I heard you correctly, that it led to the overstocking of a particular method. So it has to tie in with what happens within the consultation between the provider and the user, which then links up also with the supply chain. Thank you.
Thank you. My name is Gloria from Ghana, Ghana Health Service. I want to congratulate the team for doing the very good work and being in there, owning all of this. I want to know whether these trained pharmacy technicians are working only with contraceptives and RH commodities, or are they working generally to improve the other commodities? Thank you.
Because of the challenges of human resource, we decided to train these pharmacy assistants to handle all pharmaceuticals and supplies at the health facilities. So he's like a champion of the pharmacy and pharmacy supplies at the health facility. Thank you.
Okay, one last question. Back in the back, way back.
Hi, everyone. Stephen Harsano from the William Davidson Institute. I'd be interested in hearing, in the case of Malawi, if there are similarities and differences that you're seeing in the urban versus the rural last mile, both in terms of the problems you're seeing as well as the solutions. And the reason I'm asking, I think, is because it helps also shape our thinking about where we invest, how we get the most reach in the kinds of solutions that we're looking at. Thanks.
Thank you very much. Indeed, there is some difference. In the urban areas, you would have those facilities properly manned and with almost all the health workers that are needed, as opposed to the rural area, which oftentimes are hard to reach, and we have the dirt roads that we saw in the film. And at times you would actually have providers not willing to work at the hard-to-reach areas. So those are the areas where we are concentrating most, because they would have all most of the challenges. And like we said, 85% of the population is actually in the rural area. That's why for our COP, we concentrated in the health centers, which are in the hard-to-reach areas, so that we should have the problems alleviated at those.
And just to add on to that, at the Malawi has a three-tier kind of health system. Is at tertiary level, which are referral hospitals, and secondary level, which are district hospitals. And at the primary level, we have these health facilities who also service community health facilities. So at the referral hospitals, you have pharmacy technicians and pharmacists manning the commodities there. Whereas at the secondary level, you have pharmacy technicians who are trained at the diploma level to manage commodities and other logistical requirements. But at the health center, which is the primary one, that services 85% of the population, there was no any trained professional working at that level. As a result, the community health workers who are working at that level were only given a 2-week orientation, and you know what that means when it comes to managing commodities at that level. Thank you.
Great.
Also, just to say that when we're during the project of COP for contraceptive security, the whole reason it was there, because it was facility-based, and every facility was able to identify the problems that there were. And some of the problems would be like as you said, stockhouse or indeed overstocked. And then each facility was able to say, why do we have stockhouse? Or indeed, why do we have overstocks? So they would come up with root causes and be able to recommend. And if they recommend that they wanted a person designated responsible for procurement and requisition, that's a recommendation, and that would go through the ministry, and the ministry would be responding.
Great, thank you. I want to end by sharing a few comments and then letting Fannie sort of close with some of the priorities of Malawi going forward. But I think what we've seen and what we hear are really these themes about human resources and the need for information and a lot of the challenges at the last mile that our groups have been really working to overcome. The real need for partnership and collaboration, particularly in working at this level, as well as the Ministry of Health leadership, governance, and ownership of all of these programs. And so I personally want to commend Fannie and her team at the ministry for their overall guidance and support in providing services in Malawi, and would like to give her the floor to close us with some of her thoughts.
Thank you very much. I think for Malawi, we would want to scale up the COP for contraceptive security so that we have the bigger impact. Like you heard, it's in 60, but we have over 400 primary health care facilities. We would want to have a pharmacy assistant at all the primary health care centers so that they should be able to update the logistics management information systems. And we know that with concerted efforts toward achieving commodity availability, our clients at the last mile will be satisfied. So that's how we want to proceed as Malawi. Thank you very much.
Thank you.